to come in for routine laboratory monitoring. So go ahead and vote. Okay. And it looks like we have enough votes here, so I'm going to end the poll, and let's broadcast the results. Okay. And we have here, most of the people got the answer right, so we won't have to spend too much time on that. Let's move on to the next polling question. So the IMPACT 2010 study compared 3 different strategies for HIV treatment in women diagnosed with HIV during pregnancy. What was an important finding from this study reported at CROI 2020? Choice 1 is dolutegravir-based therapy was associated with an increased risk of neural tube defects. Choice 2 is TAF-FTC plus dolutegravir led to excessive weight gain compared to women without HIV. Choice 3 is women receiving dolutegravir were more likely to have viral suppression at delivery than those receiving efavirenz, and TAF-FTC was safer than TDF-FTC. And choice number 4 is treatment-emergent resistance was lowest in those receiving TAF-FTC plus dolutegravir. And go ahead and vote. This is about the IMPACT 2010, and the people in the IMPACT network would be angry with me for misspelling their network's name, which really should have 2 A's in it. That's my mistake. Okay. So now we're going to end the poll and see the results. And we'll come to this study in more detail because I think it actually was probably the most important study for clinical practice at the meeting. And question number 3 is about the Atlas 2M study, and what did we learn about long-acting injectable cabotegravir plus rilpivirine? Choice 1 is that injection site reactions were moderate to severe in 20% of participants. Choice 2 is that there were significantly more treatment discontinuations in the every 4-week arm. Choice 3 is that no study subject developed treatment-emergent resistance. And choice 4 is that patients preferred every 8-week over every 4-week injections. All right. We've had some time to vote. So let's end the poll. And here's the results. Okay, we'll cover the Atlas 2M study as well. Let's move to the next and final pretest question. Oops. I'm sorry, that was the final pretest question. I know that you were just dying to do questions the entire time, but let's start us off by just talking about what actually happened at CROI 2020 in Boston related to COVID-19. So let me take you through the timeline of living in the city, which is where I live. CROI's been here many times, and it's a wonderful place to have CROI. But on February 21st, in the United States, hard to believe, there were only 30 confirmed cases of COVID-19, and Boston at that point had 1 confirmed case. However, on the 26th of February to the 27th, there was a Biogen executive conference in Boston, and shortly thereafter, Biogen notifies employees that many who had attended had become sick, and this is on March 2nd, later confirmed to be COVID-19, and over 100 cases actually were linked to this meeting. At that point, very wisely, the people in charge of CROI 2020 made the decision to convert it from an in-person meeting to a virtual meeting, and I have to give credit to the organizers for making this decision. In hindsight, if they had not done so, imagine the sort of painful irony of this conference filled with people studying an infection where you ended up having an amplification of what was really an exploding epidemic in the United States at the time. Just want to mention some numbers. At the end of February, at the time, this, just around March 1st or so, February, March 1st, there were about 60 to 100 confirmed cases of COVID-19 in the United States. And in hindsight, we know from epidemic curves that there probably were closer to 10,000 at the time. And this had to do with a tremendous limitation on testing that we had nationally. So this was not the only thing that happened at CROI 2020. The people coming to Boston for the meeting, to run the meeting, including the estimable Mike Sag, were here in Boston running the virtual meeting. And Mike, as you might know, is one of the real leaders in HIV medicine for many years. And he actually came down with COVID-19, either here in Boston or down in New York visiting his son. And he has made a very nice recovery, and he's been very public about the experience. And I highly encourage you, if you haven't seen any of his writings on this, he wrote a very nice piece in the Washington Post also. He describes the experience of having this infection and just how terrifying it is. So I'm glad to say that Mike has nicely recovered from this. But everyone who's had it, and even the people who've recovered, experience a very profound and long post-illness fatigue, which he had as well. All right. Let me cover a little bit of the latest research in COVID-19. I don't want to go into too much detail because that's not why you joined this webinar. I just want to say that keeping up with this, everybody uses the same metaphor, which is it's like drinking from a fire hose. But I actually was talking with Helen Branswell, who's a reporter for Stat News, and she is Canadian. So I said, well, how about Niagara Falls? And she said, yes, it's like standing under Niagara Falls trying to get a glass of water. That's what it feels like keeping up with this literature. But here are some of our latest findings. We now know that people have peak virus in their upper airways one day right before symptom onset, and then the day that symptom onset happens as well. Those are the periods of highest viral shedding. Over time, the virus descends into the lower tract, and then at that point, often it's negative in the upper airway and positive in the lower airway, so endotracheal samples or sputum samples. Another thing we've learned is that certain people have very prolonged shedding of the virus, and that virus is shed for weeks in some people, even people who've had mild illness, but particularly after critical illness. The most striking finding in the last couple of weeks about asymptomatic disease has been in people who have are in high incidence or prevalence areas, and they get screened, and lo and behold, a significant fraction of them are positive. And so there have been studies now in pregnant women and people who are living in homeless shelters and in nursing homes, finding a high proportion of people with infection who do not know they have it. We now know that many people are seropositive. They've had the infection and have developed antibody. That varies from a couple of percent to as high as 25 to 30%, depending on the region. And what we don't know yet is whether this antibody positivity confers lasting immunity to getting infected again. And then the most exciting thing was what we just learned this past week was about remdesivir, and remdesivir having in a clinical trial of people with moderate to severe disease demonstrating a faster time to recovery than people who received control treatment. So that has led to an emergency use authorization for remdesivir that is being sorted out this very week as we are having this webinar. So that's, well, I'm going to talk about COVID-19. I'm going to shift now and talk about COVID. Oops, I forgot about this. What about COVID-19 as it relates to HIV? Well, as you may know, the disease course in people with HIV, thus far, we don't notice any differences. There's a lot of observational anecdotes out there. Some people say the disease is milder. Some people say that the disease is more severe if they have comorbidities. Other people say they're protected because they're taking, various antiviral agents. The bottom line is we don't really know. I think it's fair to assume that well-controlled, healthy people with HIV probably don't have more severe disease. I think that's pretty much known. But this one right here, what about the people with advanced immunosuppression? Well, they don't typically handle any infection very well, so I would imagine that this would be more severe in them, but again, we don't have enough information. One important stress, this one right here, if our patients with HIV are virally suppressed and in stable health, we can defer some of their routine visits and laboratory visits. You can do virtual visits. You can do lab visits delayed by a few months when the peak of the epidemic is over. I think that's wise to do. Very important is supply of medications. And then this last one is just makes sense. There's some in vitro data that lopinavir or ritonavir might have activity against some coronaviruses, but not sufficient to warrant making any changes to someone's antiviral regimen. So those are some guidance that came out in late March from the DHHS. There are also some nice CDC recommendations that have very similar statements. So let me start with talking about epidemiology and prevention. Now back to HIV. No more COVID-19, at least not in these upcoming sections. First, I want to mention the striking correlation between community viremia in Australia and HIV incidence. This is really amazing. You could barely come up with better lined up data curves than these two. What we've seen in the 2010s is a huge increase in the proportion of people who are on therapy and virally suppressed in certain communities around the world. And one of them are these cities in Australia, and basically what my colleagues in Australia tell me is that so many people are on treatment and suppressed that it's very uncommon for them to see a new diagnosis these days, which is actually excellent news. And this has corresponded with an increase in uptake in pre-exposure prophylaxis. So anyway, this happened in Australia before they started using PrEP, and now this decline has even accelerated. So what we have in Australia is in some ways the best case scenario for people who are trying to work on HIV prevention, because they have a decline in community viremia and they have a marked increase in the use of pre-exposure prophylaxis. One thing I've always liked are the Kaiser cohort studies, because they actually show in some ways the American healthcare system and HIV at its best. Obviously, everyone in the Kaiser health program has full access to medications and is fully insured. And what Kaiser has shown over time, if you look on the horizontal axis, these are the years, over time the gap between people who are HIV negative and people who are HIV positive in terms of survival is narrowing a lot. And the one thing I want to stress is this first sub-bullet here. There's actually no gap if people start HIV therapy with a CD4 cell count 500 or greater. That's really remarkable, and that's wonderful news. The slight downside to this is that people with HIV continue to have a lot of comorbidities. Some of these are related to just aging, but this is adjusting for that. But a lot of it is sort of lifestyle factors that some people with HIV have that lead to increased comorbidities. And then there's also the kind of the toxic effects of some of our early antiviral agents that I think we're still struggling with. One thing also that's always worth keeping an eye on is how much drug resistance we have in our country. This is a good news slide. It takes a look at de-identified samples submitted for drug resistance, over 80,000 of them from the 6-year period, 2012 to 2018. And what you'll notice from the figure is that the proportion of cases with significant multi-class resistance has dramatically dropped. And that's excellent news. These are the hardest people to treat. What I would postulate this is from an increased adoption of integrase-based therapy that has a high resistance barrier, in particular dolutegravir, because it's very uncommon these days to have a patient who has such high-level resistance to dolutegravir or Bictegravir that they can't maintain viral suppression. And now getting back to a familiar study to most of you is the DISCOVER trial. There's Discover was a placebo, it's actually a double-blind study, no placebo, except matching placebos of the active agents of FTC-TAF and FTC-TDF in MSM and transgender women. We've already seen 48-week results. These are men and transgender women who deemed to be at high risk for acquiring HIV because of these risk factors outlined here. And this is just a further extension of the results. Since the previous report, there's one additional case of HIV transmission, and numerically still favoring FTC-TAF, but it's not statistically significant. It's certainly not inferior. In the FTC-TAF arm, those who acquired HIV actually did not have any incident FTC or TAF resistance, and those in the FTC-TDF arm, 4 out of the 13 did have genotypic resistance. One thing that people always ask about now in all HIV studies is weight. This weight issue, I'm going to come back to it repeatedly in the course of my presentation. Over time, the people in the FTC-TAF arm did gain more weight than the people in the FTC-TDF arm, and this corresponded to an increase in the BMI as well. I do want to stress this last point, which is that the weight change in the FTC-TAF arm was similar to the placebo arm of the IMPAACT PrEP study, which means that what we're seeing to some extent, at least, we don't know if this fully explains it, is an effect of TDF on weight, and we're going to actually see something TDF on weight. It may be augmented by efavirenz. So this is a interesting finding from the FTC-TAF versus FTC-TDF Discover study. I thought this is a remarkable study. This is looking at 2,400 or so individuals starting pre-exposure prophylaxis in a program in Thailand. It's just a huge number, and followed prospectively. And during this course of this being followed, 7 had acute HIV. Interestingly, only 3 of the 7 had persistence of any sort, M184V only, and then very importantly, no one acquired tenofovir resistance. 4 of 7 had no resistance, and if we take a look at the group who had no resistance, you can see they were not taking PrEP for very long versus this group. So it seems like the duration of the PrEP is longer in people who develop resistance. I guess that is to be expected, but still is very much, how do I put it? It's good to see this confirmed. I think what this means is that if you find acute HIV in your patient who's taking PrEP, the sooner you can get them onto a fully suppressive regimen, the better, and you can prevent the development of resistance. Interestingly enough, also, there are a lot of the patients in this study, when they were diagnosed, they had extremely low viral loads. Remember that this 2-drug regimen is potent. It's not going to be suppressive long term, but it is quite potent, so that not surprising that their viral loads were low. And then this is a study of post-exposure prophylaxis. I got to hand it to Ken Mayer and his gang at the Fenway Community Health Center here in Boston. Whenever there's a new product that comes out, he tests it in the non-occupational post-exposure prophylaxis and gives us a sort of broader range of options for PEP. And here he looked at Bictegravir FTC-TAF, 48 individuals, comparing it to Bictegravir COBI, FTC-TDF, Raltegravir FTC-TDF, and a protease inhibitor plus zidovudine, lamivudine. And these are historical controls. And really what they're looking at is they're looking at the regimen completion. And what my slide can show you is that you've got over here, over time, an increase in the proportion who complete the regimen, 39%, 57%, 71%, all the way up to 85%. And if you think about it, it's actually Bictegravir FTC-TAF is an ideal drug for this indication because what we want to do is give the simplest possible treatment to people for them to take this regimen for 28 days and complete it with the fewest drug interactions, etc. So I think it's nice to have this in the in our potential options for PEP. I do have to bring up the vaccine study. I know that I like to be I'm an optimist by nature. I like to cover good news. Unfortunately, not a lot of good news on the vaccine front, including the fact that the HVTN study, which started in October of 2016 and was a modification of the only signal we've had from any human study that a vaccine might work, that was from the TIE study. This is a modification to make it broader and more immunogenic. And it was tested in South Africa in both men and women at risk for HIV, and it ended up being stopped right before CROI, a month before CROI, due to futility. And if we take a look at the figure from the presentation, you can see why the Data Safety Monitoring Board did stop the study. You have women at the top and men at the bottom, and for the active placebo component, active vaccine versus placebo, you can see there's really no difference at all, and this is a huge disappointment. I do want to mention, though, that there are these two other vaccine studies going on right now using this mosaic multi-clade approach, one in women in sub-Saharan Africa and one in men who have sex with men and transgender women globally. So those two studies are ongoing, and we're waiting eagerly to hear positive results from an HIV vaccine study. Okay, now I'm going to go on to antiviral pregnancy and therapy in pregnancy and talk about the IMPAACT 2010 study. This time I spelled it right with two A's right there. And I got to give credit to my the senior investigator in the study, who's a colleague of mine named Shaheen Lockman, who's a brilliant clinical trialist. And she led this study, and it was presented by Dr. Chinula. And it basically was a study of women who were newly diagnosed with HIV during pregnancy. So they were eligible if they were pregnant at 48 to 28 weeks of gestation. They were treatment naive, but we did allow them to have taken up to 14 days of ART in the course of the pregnancy. Patients were enrolled in 9 countries, most of them in Africa. And the two major endpoints were a virologic endpoint, which was viral load less than 200 at the time of delivery. That's right here. That's endpoint number 1. And there was a safety endpoint, which was an adverse event pregnancy or infant outcomes. And the study design was as follows. At study entry, women were randomized to receive either dolutegravir plus FTC-TAF, dolutegravir plus FTC-TDF, or a control arm, which is TDF, efavirenz FTC-TDF, basically the most commonly used regimen in the world in pregnancy for some time now. This is the first time we're seeing FTC-TAF in a clinical trial that involves pregnant women, and you'll notice the sample size here. Each study arm had over 200 participants. So this is a really good-sized study, and we don't see a lot of studies in pregnant women, so I think it's important to highlight the results. Here are the baseline characteristics. See, these were young women, generally quite healthy with a high CD4 cell count. You'll note that the HIV viral load is relatively low at around 900 copies, and that's because remember that the women were allowed to take up to 2 weeks of antiviral therapy before entering the study, and they had taken over 80% of them had taken something for about a week. I should mention also, I think I did mention it, I'm going to mention it again, almost 90% of the study subjects were enrolled in Africa. So here's the primary result of the virologic outcome. It's that the dolutegravir arms outperform the efavirenz arms in terms of this very key result, which is the proportion of individuals who are virally suppressed at the time of delivery, 97.5% versus 91%. So this not only met the non-inferior threshold, but also was superior. So dolutegravir is superior to efavirenz. And then for the safety outcome, this is in orange is the dolutegravir plus FTC TAF arm, and then gray is the FTC TDF dolutegravir arm, and blue is the efavirenz FTC TDF arm. And what you'll note is that for the combined outcomes of preterm delivery, small for gestational age, and stillbirth, that the safest of the regimens was the FTC TAF plus dolutegravir arm. Again, this is the first time we've seen really prospective data of FTC TAF in pregnancy. So to shift now and talk about what everyone talks about, which is weight, let's look at the weight changes in the course of pregnancy. And here, what we see is that the dolutegravir plus FTC TAF arm, the women gained more weight than in the other two arms. And we're not surprised to see that at this point because, of course, the dolutegravir plus FTC TAF arm has been associated with excess weight gain in multiple studies. But the dotted line is an important line because that's actually the recommended weight gain for second and third trimester women who are HIV negative. So in some ways, the women in the FTC TAF dolutegravir arm had actually the most physiologically normal weight gain during the course of this pregnancy. So to sum up this important study, for women diagnosed with HIV during pregnancy, dolutegravir is preferred over efavirenz-based regimens based on a high viral suppression at the time of delivery. This does not address the dolutegravir risk of neural tube defects issue, which remember is dolutegravir at the time of conception. This is very different. I want to again say that TAF FTC was better than TDF FTC for pregnancy outcomes, in particular for preterm delivery and small for gestational age. One thing I forgot to mention that I should have mentioned, there were two babies who acquired HIV in this study. One, in a study subject who was not taking her medications, and the other in a study subject who did have viral suppression, and in hindsight, there was probably an in utero transmission. And then the last point is that the weight was greatest with dolutegravir plus TAF FTC, but that was closest to the recommended weight gain during pregnancy. So getting back to our question, remember I asked about the outcomes of the study, and here they are for you, so that when you take the test question at the end, you'll be able to get the answer right, which is that dolutegravir is preferred over efavirenz and TAF FTC is safer than TDF FTC. All right. How about we talk about that weight issue? Everybody's talking about it, so let's talk about it some more. First, let's look at ADVANCE. ADVANCE is 96-week metabolic outcomes. Okay, the phase 3 study, we've seen the results published in the New England Journal of Medicine. This is focusing on the metabolic outcomes. Remember, conducted in South Africa. Basically, most of the participants were of African descent. 60% were women. Some did have obesity at baseline. And then what the study has already reported is that they had a high rate of treatment-emergent obesity, in particular in the women, in particular in the dolutegravir plus FTC TAF arm. And so what the investigators here did was they tried to predict cardiovascular risk using the Framingham equation, and then used something called Q risk and Q diabetes to predict heart attack and stroke. And those results are shown here on this slide. yes, there does not appear to be a difference in cardiovascular risk, but of course this is a relatively young participant, so there was no projected Framingham differences. But from the Q risk and Q diabetes arm, there is predicted higher incidence of these complications over time for the dolutegravir plus FDC TAF arm, and that is due to this weight gain. So this is projecting forward. These were not actually observed differences in the study. This is an interesting cohort study going back to the outcomes after pregnancy, and this shows postpartum weight gain through 18 months was significantly greater with dolutegravir-based ART versus efavirenz-based ART. What was interesting is that they also included a group who had no HIV at all, and what you'll note is that the no HIV group has very similar weight gain to the dolutegravir group, whereas the least weight gain was in the efavirenz gain arm. So what we saw already is that it does appear that TDF may have a weight suppressive effect, but it also looks like efavirenz has a weight suppressive effect, at least in these postpartum women. Weight gain in the women getting dolutegravir was comparable to the women who don't have HIV at all. And that is shown in this figure of lots of little dots. If you take a look at the dolutegravir arm is here is this brown one, and then this in very parallel one is the HIV negative one arm. You can see they're virtually exactly the same amount of weight gain. They just start at different points. And the efavirenz one is actually just the opposite. There's weight loss. I mean, who knew that efavirenz was inducing weight loss? I certainly didn't before all of these studies. And on a related issue, let's talk about CYP2B6 genotypes. CYP2B6 genotypes might be familiar to you from other studies. Remember, people have this genetic profile that either has them metabolize efavirenz quickly, so they have low efavirenz levels, or they metabolize efavirenz slowly, so they have high efavirenz levels. So we have extensive metabolizers, intermediate metabolizers, and slow metabolizers, okay? And they're shown in this figure here. And this is the weight changes in people who are metabolizing efavirenz quickly, right? And it's very similar to the dolutegravir arm, whereas people who have slow metabolism, their weight is actually lower. So the fast metabolizers gained similar weight gain to dolutegravir, suggesting that higher efavirenz levels are suppressing weight. Fascinating. It's like a dose-response weight issue. I don't know if you recall this analysis that we did in the ACDG, looking at suicidal ideation using the same CYP2B6 genotypes, and we found that people who were slow metabolizers of efavirenz actually had a higher risk of suicidal ideation from efavirenz. Again, the same kind of dose effect. That the higher the levels, the more that this efavirenz effect is seen. In the study I mentioned, it was suicidal ideation. In the study I'm presenting here, it's actually weight loss. So that's some new information on weight. We're now going to talk about miscellaneous antiviral studies and those blips and that low-level viremia that drive us all crazy, including me. All right, moving on. So first, let's talk about the TANGO study. Okay, the TANGO study is a very important trial which looked at people who are suppressed on a TAF-based regimen and have never failed treatment. Okay, so that's they have no history of no known history of resistance. What this study did was it now went back into this patient profile, people like this, people who have never failed therapy, and have tried to find resistance in the baseline population using archived genotype. So not surprisingly, there weren't a lot of people in this study who have a lot of resistance, but there were some. And I think what this is showing us in this figure is that whether you're on the dolutegravir 3TC arm, that's the 2-drug arm, or continuing your TAF-based regimen, that's the 3-drug arm, that your chance of getting virologic failure is exceedingly low, exceedingly low. Look how low it is for both strategies. And so what I would say the take-home message from this study is that if you have a patient who's never failed therapy and has no history of resistance, it is extremely unlikely that you will find clinically significant resistance in that person that would make dolutegravir lamivudine 2-drug regimen not work. It's very, very unlikely. All right. By contrast, this is a study that was done in España, basically looking at people who do have a history of known 3TC resistance and then switching them to dolutegravir lamivudine, including some who had historical 3TC resistance. And all I can tell you here is this is a relatively small study, and they did not show that people who had this resistance were actually failing at a high rate, but it's such a small study, who knows? And the bottom line is the red stamp that I put on this slide. I do not think we should be recommending dolutegravir lamivudine for people with M184V, especially historical M184V. That's not the purpose of this regimen. And just because it worked in these small number of individuals doesn't say that we should be doing it in clinical practice. I also think it's important to remember that, in a very small study, dolutegravir monotherapy works pretty well because you may not see failures in that small group. So not recommended. So these are contrasting two different populations, the TANGO population, in whom it's quite safe, and then this population, treatment experienced with M184V, some of them with historical M184V. Don't do it. Here's a study showing that switching, that in the treatment-naive studies of Bictegravir FTC TAF compared to dolutegravir-based regimens, either abacavir 3TC or TDF FTC, that there was very comparable safety and efficacy in the population that was greater than 50 years old versus those who were younger. Okay. So let me talk now about viral blips. Viral blips are a favorite topic of HIV specialists. So many of our patients are suppressed that we have to get excited about something, and we're going to get excited about blips. Okay? So this is an analysis of blips in those 3 treatment-naive studies that I just mentioned. It's Bictegravir FTC TAF, dolutegravir abacavir 3TC, and dolutegravir plus FTC TAF. And a blip in this study was a viral load greater than 50, preceded and followed by a viral load less than 50 after achieving confirmed suppression. And the bottom line here is, despite all of the anecdotes that people always say, the incidence of blips did not differ between the arms. And I think this is important because every time we have a new treatment, people anecdotally come out and say, I think I'm seeing more blips with this than this. It really doesn't appear to be the case. And if it is the case, it's not shown in any data. It's really shown in anecdote. And I think it's just that we pay more attention to people on newer regimens. One somewhat interesting finding from this study was that the occurrence of blips appeared to be predictive of lower suppression rates in the dolutegravir, but not the Bictegravir arms. And I have no idea whether that's just a one-off from this analysis or whether it reflects anything biological. So Blips in these second-generation integrase inhibitors, the dolutegravir and Bictegravir regimens, seem to be very similar in incidence. And then here's a study I really like, and it's the NA Accord group. Remember, NA stands for North America, so this is a cohort study of people from the United States and Canada, and it looked at nearly 20,000 people followed for about a decade. And the thing that's really remarkable is the is how much data they looked at. And so they followed from the time of initial suppression until they were less than 200 copies, and then followed them for 6 years. And they categorized them by viral loads as being all the values were less than 20, or they were between 20 and 199. So looking at that group who have intermittent low-level viremia, one or more levels. And after they accounted for like baseline confounders, what this study showed was that no effect on mortality. Hooray! Both groups had a very low mortality over time, whether it was the 2-year follow-up or the 4-year follow-up. And it shows at the bottom here what it was adjusted for. It was adjusted for factors that might predict worsening outcome. So I like this NA Accord study, which makes me say, well, what am I going to do with this next study, which is this Swedish cohort? And here they found just the opposite, which is that low-level viremia during antiretroviral therapy actually increases the risk of death, AIDS, and serious non-AIDS events. And this is the Swedish registry. And they basically looked at 3 groups, people with viral loads less than 50, people with viral loads between 50 and 199 and 209.99, and then a treatment failure group. And they did find an association between the occurrence of this low-level viremia and these clinical outcomes. But I do want to say, since I like the first study more than this one, I think that they didn't do quite as careful adjustment for baseline confounders that the NA Accord group did. So I'm going to go with that one over this one. And the bottom line is we don't know what to do about these low-level viremia cases anyways, except to encourage adherence. Certainly changing their regimen does not help, although we can discuss in the question and answer period, maybe we could have a discussion about the sort of things we might consider doing for our patients who are blipping or have low-level viremia. All right, this is my last section. It's on new strategies and agents. Let's start with the Atlas 2M study, which is also the topic of one of my questions. And essentially, as you know, it was a comparison of cabotegravir rilpivirine given every 4 weeks, which is what was studied first, or every 8 weeks, a slightly higher per visit dose of the cabotegravir. And the people who were in this study were rollovers from the Atlas Q4-week study or the standard of care arm, and then they were randomized to either the 4-week regimen or the 8-week regimen. So just to tell you that the people in this study were stably suppressed before they went into this study. That's important, and stably suppressed for quite a while. And here is what the study showed, which is something actually we learned from a company press release a couple of months before CROI, which is that the strategy of every 4 weeks and every 8 weeks were non-inferior. The every 8 week was non-inferior to every 4 weeks. You can see the very low rates of virologic failure. There were some people who developed treatment failure and some people who developed emergent resistance to rilpivirine, in particular, and then some new genotypic correlates of dolutegravir and resistance, and they're shown here. These are the table of the confirmed virologic failures in the 8-week arm, in the 4-week arm. Even though these are extremely rare, we have to focus on them because otherwise, what would we focus on? I just want to say that there were some people who developed emergent integrase resistance, and this is now seen in some of these studies, but the risk is overall low. As has been shown in all of the studies, the Atlas, the FLAIR, and the first Atlas, and then the Latte study, the people going into these studies do prefer injectable therapy over oral therapy. And the people who had previously been on every 4 weeks preferred every 8 weeks, not surprisingly, because it cuts down the total number of injections by 50%. I did the math correctly. One thing that's not known is why is it that some people do fail this regimen. Remember, our oral regimens now, if people are adherent, they essentially never fail anymore, and they never fail with resistance. With this injectable regimen, a very small fraction of people, even who are quite compliant with the injection schedule, do fail with resistance. I don't think we have enough information to know what the predictors are of this phenomenon are quite yet. Okay. So some additional studies of interesting agents. I do want to mention the extension of the FLAIR study. No new cases of virologic failure in that study. That's very encouraging between weeks 48 and 96. Islatravir, which is the long-acting nucleoside reverse transcription translocation inhibitor, and very potent, very long-acting. It's being combined with doravirine for a daily administration, and probably will be used for a long-acting something or other eventually. In that study, the phase 2 study, the results of which we've seen previously, had less effect on bone mineral density than a TDF-based regimen, and the weight changes were similar. There are 2 tenofovir prodrugs that were presented that have low plasma levels and very high intracellular half-lives. And then the capsid inhibitor showed very, very potent antiviral activity with a single subcutaneous dose, and then also an oral formulation has been introduced. So key takeaways from CROI 2020. The data continue to support a very high efficacy of TDF-FTC and TAF-FTC for PrEP with a low risk of resistance, that there's still an ongoing search for an HIV vaccine. Bictegravir FTC-TAF is a convenient strategy for post-exposure prophylaxis. In women who are diagnosed with HIV during pregnancy, dolutegravir plus TAF-FTC may be our best regimen. This is the first safety data we've seen on TAF in pregnancy. We already had safety data on dolutegravir started during pregnancy, shows it's very, very safe. We know that weight gain is more common with dolutegravir and TAF-based regimens, but the mechanism remains uncertain, especially when comparing it to drugs that appear to have a weight suppressive effect, in particular TDF and efavirenz. Viremia is still a puzzle, but it keeps us in business. Cabotegravir or rilpivirine every 8 weeks is very promising with a very small risk of resistance, and there are also several promising investigational agents in development. So next year's CROI is going to be in Chicago, March 7th to 10th. And I was just chatting with Donna right before this presentation, and we don't yet know whether that's going to be an in-person or a virtual meeting. Let's hope by then we have resumed our ability to have face-to-face meetings, but if not, credit to the CROI organizers for putting on this virtual CROI with such skill. So now, going back to my questions, here are my questions. First, about the advice for people regarding COVID-19, people with HIV with COVID-19. Everyone is voting here, and let's see if we can get 100% to vote correctly. Greater risk of severe disease, or should practice social distancing and hand washing. Whenever an ID doctor says hand washing, you know that's the right answer, right? Right. Okay, so let's end this poll with a huge proportion of people getting it right. Yay. Okay, great. So 99%, that's pretty good. Let's go on to the next post-test question. IMPACT 2010 compared 3 different strategies for HIV treatment in women diagnosed with HIV during pregnancy. What was an important finding from this reported at CROI 2020? One is that dolutegravir-based therapy associated with increased risk of neural tube defects. 2 is that dolutegravir, but TAF-FTC plus dolutegravir led to excessive weight gain. 3 is that women receiving dolutegravir were more likely to have viral suppression at delivery than those receiving efavirenz, and TAF-FTC was safer than TDF-FTC. And then last is that treatment emergent resistance was lowest in those receiving TAF-FTC plus dolutegravir. And the correct, we're going to see now whether most of you got the correct answer, and most of you did. The correct answer was 3, and that it was dolutegravir was better for viral suppression, and TAF-FTC was safer for the pregnancy outcomes. All right, next polling question. In Atlas 2M study, what did we learn about long-acting cabotegravir plus rilpivirine? 1, injection site reactions were moderate to severe in 20% of participants. 2, there were significantly more treatment discontinuations in the every 4-week arm. 3, no study subject developed treatment emergent resistance. Or 4, patients preferred every 8 weeks over every 4-week injections. And again, such a smart group, it's over 90% getting the correct answer, which is 4. So, all right, there we go. Thank you all very much for your listening, and so let's take a look at some of the questions. Are there drug interactions between remdesivir and any HIV medications? I know that the clinical trial we're doing is does have some exclusionary medications, but rather than give you the wrong answer, I'm going to say let's let one of our very smart PharmDs answer the question, because I know that there's a large group of PharmDs who are HIV specialists. So rather than get it wrong, I'll let them answer. Risk factors for HIV acquisition in the Discover trial. Well, if I could have the Discover slide back up, I know it's way back because we'll go over the. Can I go back to probably about slide number 15, I'd say, or do I have to go back manually? I'm going to go back manually. I'll get there eventually, but it was the typical things that you would see in a study of PrEP. Where you have basically study of PrEP, you get, I'm going to get there right now. I'm going to go to it right now. Here we go. I'm going to make this slide big. Thank you. And HIV risk factors. 2 or more condomless anal receptive sex acts in the past 12 weeks, rectal gonorrhea, chlamydia, syphilis the past 24 weeks, recreational drug use past 12 weeks, binge drinking. So they had to be have at least some known HIV risk factor just to get in. Could not be just in HIV-negative MSM or transgender women. Infant outcomes in IMPACT, there were two infants who acquired HIV. I mentioned one was born to a woman who was not taking medications. Her viral load was 58,000. And the other was a woman who had viral suppression at the time of delivery and is currently being investigated for whether that was intrauterine transmission. It actually does sometimes happen. I do want to mention that there is that the perspective on this was really remarkably different from our experience. We don't, of course, in the United States have nearly as many pregnant women with HIV as they do in Africa. And the investigators from Africa were thrilled that there were 2 transmissions in this study of over 600 participants. We, of course, in the USA, with far fewer numbers, don't see any transmissions at all, basically, for women who take their therapy. So you can all but guarantee that it won't happen. But remember, they entered the study between 14 and 28 weeks gestation, so there was a period of time before they were on ART. How is adherence measured in the IMPACT study? Well, I mean, one way it was measured was virologically, and there was almost nobody who had virologic failure, but the people with virologic failure were the ones who were non-adherent. Okay, I have a web ability to look up remdesivir right now. No, I can't see, and I'm just going to say that if you take a look in the chat box, there is a wonderful description of the possible interactions. Okay, next question, how would you manage patients with viral blips? So patients with viral blips, most of the time what I do is if there are people who have no history of treatment failure and they have one of these, they've always suppressed and then it comes back and the result is 72 copies or it's 66 copies, I try to reassure my patients that this happens sometimes and tell them to come in, keep taking their medicines and come in next time and get their treatment, get their therapy monitored as usual. If it's someone who has persistent low level of viremia, it's a little different. I want to make sure that they're followed much more closely. That's different than the occasional blip. I think in general we should have our patients who have low-level viremia on high resistance barrier regimens. So that means a second-generation integrase inhibitor or a boosted protease inhibitor. But I also don't think that by switching their regimens, in fact, I'm sure you don't typically get rid of the tendency to blip, unfortunately. Oh yeah, this is about weight. Presumably the efavirenz arms are on efavirenz, FTC, TDF. Are we saying the efavirenz was the cause of the weight loss and not the TDF? Well, the reason why I mentioned these 2B6 genotype study is that the 2B6 genotype really correlates very strongly with the efavirenz levels. And in the advanced study, it was people with the highest efavirenz levels who had the least effect on weight, and the people with the lowest efavirenz levels had weight that was comparable to dolutegravir. So I think actually there is evidence now that both efavirenz and TDF, and maybe the two of them together, really do contribute to an effect on weight. The adherence in the Atlas 2M study was excellent, just as it was in the New England Journal of Medicine study. How do we combat low-level viremia? I think we know the risk factors for low-level viremia better than we know what to do about it. People who have persistent low-level viremia are more likely to have had very high baseline viral loads, very advanced disease, and some studies suggest they're more likely to be on a boosted protease inhibitor rather than a non-PI-based regimen. How do you counsel people with low-level viremia less than 200 about the U equals U? A source of much debate. I can tell you that the people who are less than 200 ask this question all the time. I do tell them that the studies looking at U equals U all use 200 copies as their cutoff for viral suppression. What we don't really know is what proportion of those who were in those studies were between 50 and 200 versus less than 50 or less than 20. So probably it means that they're fine, but we don't actually know that as a fact. Okay, so I think that is, I'm not sure. I'm going to take we got a couple of more minutes. I'm going to take a few more questions. So this is about COVID-19. Are HIV patients with controlled viral load at higher risk of COVID-19? So far, as I mentioned, the observational data do not support that they are, and there's all kinds of anecdotal data that, quote, they might be protected, but I don't really know. How about using lamivudine and dolutegravir in switch patients who have the M884V mutation? I'm going to, again, give you my opinion. I think that even though this small Spanish study suggests it might work, that's not who this regimen's for. The dolutegravir lamivudine regimen is not for people with lamivudine resistance. And I think that brings us to a couple of other questions, and then I'm going to, okay. So is there enough evidence out there to support the use of archived genotypic tests performed in people who are already suppressed on older regimens and are considering a change to something new? This is a good question. I'm going to finish up with this question. I think that's is that right, Jose? Am I right to this? I can't remember whether this is goes to 2 or 2:15, but I've been talking for an hour, so I'm getting tired.
So the presentation, you may extend the Q&A up to 11:15 Pacific time.
Okay. Well, anyway, I'll answer a few more questions then. So basically, the archive resistance tests, if you find resistance,